Hello, future coders, and welcome. So glad you're here. If you've ever cracked open your CPT book to the musculoskeletal section and felt that little wave of panic looking at all those codes, hey, don't worry, you've absolutely come to the right place. Today, we're going to demystify some of the trickiest guidelines in this section, and we're going to turn that confusion into some serious confidence. So, here's our game plan for today. We're going to start with the absolute #1 rule for casting and splinting. It's a big one. Then we'll jump into decoding the different ways fractures are treated. After that, we'll figure out how to size up soft tissue tumors. And finally, we'll tackle the unique logic behind coding for bone tumors. Sound good? Let's get into it. All right, first up, let's talk about casting and splinting. We're starting here for a reason. This rule is so fundamental, you'll see its logic pop up everywhere in musculoskeletal coding. Seriously, think of this as your foundation. If you can get this right from the very beginning, everything else just gets so much easier. And here it is, the core rule. You might want to highlight this one in your mind. The very first cast or splint that gets put on and taking it off later is always considered part of the main procedure. It's bundled in. So when a doctor sets a fracture, the CPT system just assumes that applying that initial cast is part of the job. You don't get to bill for it separately. It's a package deal. But there are always exceptions to the rule, right? So let's get into the details. First, while the service of putting the cast on is included, the actual supplies, like the fiberglass itself, can usually be reported separately with an HCPCS code. Second, what if the patient comes back a few weeks later and needs a new cast? Well, that replacement cast is a whole new service, and you can absolutely code for it. Same goes if the cast is taken off by a completely different doctor. And one last thing, and this is huge for your exams, putting on a cast is not preoperative care, so you would never, ever use modifier 56 for it. Okay, so this brings up a super common situation. Picture this. A patient walks into your clinic. They broke their arm on vacation, got a cast put on in Florida, and now they're back home. All your doctor is doing is taking that cast off. How in the world do you code for that? You're going to love this. It's actually really straightforward. The CPT book has a specific little section of codes just for this. You'd look in the 29700 range to report only the removal. It's a perfect example of how the guidelines account for these real-world scenarios. Okay, so we've got the cast covered, but what about the reason the cast is there in the first place? Let's move on to the fractures themselves. And listen, this is so important. The way a fracture is treated is everything when it comes to picking the right code. First, we have what's called closed treatment. The key word here is closed. It just means the doctor's fixing the fracture without surgically cutting the patient open to see the bone. Sometimes that just means letting it heal, and other times it involves manipulation. That's where they physically push the bones back into place from the outside. Next up is this kind of middle ground option, percutaneous skeletal fixation. Think of it like this. The doctor isn't making a big incision, but they are inserting hardware, like pins, through little pokes in the skin to stabilize the bone. The key here is they can't actually see the fracture with their own eyes. They're using an X-ray to guide their work. And finally, open treatment. This one is pretty much what it sounds like. The surgeon makes an incision, moves the tissue aside, and gets their eyes directly on the broken bone to fix it, usually with plates and screws. So, real quick, closed means no big incision, percutaneous means pins through the skin, and open means surgery where the doctor can see the bone. Okay, lean in for this one, because this is probably one of the biggest concepts that trips up new coders. Just because the diagnosis is a closed fracture, meaning the bone didn't break the skin, that does not mean it automatically gets closed treatment. A really nasty closed fracture might need full-blown open surgery. And on the flip side, an open fracture could sometimes be managed with closed treatment. What matters is what the surgeon's report says they did, not the initial type of fracture. Now, we mentioned traction a minute ago. It's important to know there are two main types. Skeletal traction is invasive. We're talking pins and wires drilled right into the bone to pull it into alignment. Skin traction, on the other hand, is totally non-invasive. It just uses straps and weights on the outside of the skin. As a coder, seeing these terms helps you build a clearer picture of what really happened. All right, let's switch gears. We're moving away from bones and into the tissues around them, specifically soft tissue tumors. When you're coding for the removal of these, there are two questions that should immediately pop into your head. Where is it? And how big is it? So the first big question is about depth. Is the tumor subcutaneous, which means it's in that fatty layer just under the skin, sitting on top of the deep fascia? That's that tough cellophane-like stuff that wraps around our muscles. Or is it fascial or subfascial, meaning it's way deeper, maybe even inside the muscle itself? For both types, your code is going to depend on the body part and the size. And that's the size of the tumor plus any extra margin the surgeon took out around it. Okay, here's a classic little trick question. You're reading a report for a tumor removed from a finger. The surgeon says the tumor was deep and it was right up against the tendon, just touching it. Does that automatically bump it up to the more complex subfascial code? And the answer is no. This is a super specific guideline that catches a lot of people. For fingers and toes specifically, if the tumor is just touching those deeper parts, you still code it as subcutaneous. It's one of those little details that makes all the difference. Great one to remember. All right, for our last section, we're going even deeper. We're talking about tumors in the bone itself. Now, I need you to forget everything we just said about size. Just toss it out the window, because when it comes to bone tumors, the coding logic is completely different. Here is a huge do not right from the guidelines. When a surgeon does a radical resection of a bone tumor, they almost always have to take a big chunk of the muscle and soft tissue around it. The key thing to know is that CPT considers that soft tissue removal to be part of the main procedure. You can't take out that part of the bone without taking the tissue attached to it, right? It's all one package deal. You do not code it separately. So, if size doesn't matter, what does? For bone tumors, it all comes down to one thing and one thing only: location. That's it. Was the tumor in the collarbone, the upper arm, the thigh bone? That is what picks your code. I don't care if it was 2 centimeters or 10 centimeters, benign or malignant doesn't matter for code selection. It's just, where was it? And this slide right here, this is the money shot. This is the one to sear into your brain. It perfectly sums up the difference. You see soft tissue tumor, you ask two things: where is it and how big is it? But you see bone tumor, you only have to ask one simple question: where is it? That distinction alone will save you so much time and get you to the right code every time. So, there you go. We've walked through the essential rules for casting, we've decoded fracture care, and we've untangled the very different ways we code for soft tissue and bone tumors. You now have the what and the why to look at these reports with so much more clarity. So, which one of these scenarios do you feel most ready to tackle right now? Hold on to that feeling, keep practicing, and you are going to master this section. You've got this.